I'd like to thank the organizer again for letting me participate. Great discussion so far, great meeting. So I'm going to show just a few cases that kind of thought maybe we should have gone surgery earlier, thought about bypass. These are my disclosures. So CLI patients and bypass, I think it's important to look at, what are the factors to consider? And, it's funny that it's related to the patient more than just the lesion type. You're looking at patients, what their 2-year survival, are they ambulatory, what are their comorbidities, deciding what the right patient is to treat, whether one to revascularize. Are the lesions multi-level, infrapopliteal? And what have we learned from surgical trials, PREVENT-3, basal trial, looking at, limb salvage rates over 85%. And most of the data and trials that we have show great limb salvage rates, either whatever we do. And then understanding what is the vein status of the patient and when to evaluate that vein status. And I think we've learned really from Best CLI to do that as quickly as possible. With patients, we consider a bypass over even thinking endovascular, things that lesions that involve the common femoral, particularly distal common femoral artery involving profunda SFA origins. Again, trying to protect the profunda femoral artery at all costs. Severely calcified superficial femoral arteries and popliteal arteries, really questioning what the long-term patency of these interventions are. Small vessels, long segment disease, and really very limited distal runoff vessels. My first case is a long and severely calcified lesion to 52-year-old female, non-diabetic, non-smoker, really presenting with rest pain. You can just get a look of her CTA and you can see some idea of that there is underlying calcification in these arteries, the ortoiliac segment as well as the femoral popliteal segments. You look at her non-invasive evaluation here and she really had a history, 8 weeks left foot pain. So again, is this chronic? Is there an acute component? Really, what are we looking at? We thought that most of this was chronic, but like we all know, whenever you always have to keep the acute component in the back of your mind. But you can see flat waveforms in the PPGs in the left foot and real severe dampening of the waveforms from above until below knee areas. Here we go. So patient went to angiogram. We said, let's see what's going on. You can see the aorta. You can see the size of these vessels. You can see the SFA and really an occlusion of a very small SFA, which occludes above the popliteal artery, probably right at the level of P1 segment, with reconstitution of P1 segment and 2 vessel runoff, though, that got all the way down into the foot. So our concern is here, okay, well, maybe we can just revascularize and get her out of this foot pain and rather for class 3. But because of the acuteness, 8 weeks, we said, let's see if we lyse her. You can see us placing a unifused catheter over this small area and see how much, can we clean up some clot. That night, probably 4 hours later, severe pain. And this is stuff that we always, when you do lysis, what you're looking for. See, they have pain. Is the pain getting better? You give yourself a certain amount of leeway, but you expect the pain to get better. And her pain wasn't getting better, so that night we took her back to the cath lab, and you can see that the distal runoff really weren't seeing much with the catheter in place. Pulled the catheter back, kept the wire in, pulled the catheter back into more in the SFA, and were able to establish some more flow. Really didn't see any thrombus or clot, and said, okay, let's keep her overnight with some more lytics and we'll see how she looks like tomorrow. The next day she comes back and you can get, again, wisp-like vessels, really small vessels. You can see the disease that was at that distal SFA popliteal and 2 vessel runoff. We proceeded to treat this with an angioplasty and things we've talked about already, kind of looking at the lesion, how well they respond. We started with a 3 millimeter, which is pretty small, but these vessels were very small, a 4 millimeter, and thought we had a pretty good result with a 4 millimeter, but still very irregular. This is before the era of DCBs, and decided we're going to treat her with a stent in this area just because of the irregularity of this area. It was pretty much above the popliteal artery. We thought this was a good area for that. And again, 4 millimeter vessel went with a 6 millimeter Zilver PTX with immediate results looking pretty favorable. We're pretty happy. 3 hours later, she's having severe pain in our recovery area. loses her pulse. You can basically, foot is basically a white, and at this point, decide, okay, what do we need to do? We've already lysed her before. We went and talked to our surgeons, and basically, basically pulled out a bunch of thrombus and atheroma from a pretty complex, surgery, going back in the popliteal fossa and going retrograde. She did well. She's actually now out about 4 or 5 years. We've had to treat the other side because she had another episode from there, and again, did it very gingerly, but we were able to do that. And I think what we learned on this is the size of those vessels. And maybe this is a patient that we should have gone right to a surgical bypass, probably the best treatment for her. Second case, a 59-year-old Rutherford class 6, presents again with really no vessels here in the right foot from our duplex map, and CTA kind of confirms that. External iliac was out into the common femoral, and this very profound repair. Really, in this particular patient, we thought surgery wasn't, because of the extent of disease, we didn't think it would be the best for this patient. Ended up starting with revascularizing the external iliac artery and stenting that, and then a 2-day kind of trying to open up that superficial femoral artery and popliteal, some more lysis, thrombectomy, and get a 1-vessel runoff into the foot. Patient went ahead and got her trans-met amputation on day 8, and we were saying, okay, we're doing well. Prior to discharge, we evaluated this foot, and we thought, not bad, good distal target here that came back, and the PT was coming back. So, okay, we thought that was a good result. 4.5 months later, however, the patient comes back really with stump osteomyelitis, got an acute bypass. Unfortunately, that really, by this time, I think it was too late. Patient ended up with a below-knee amputation. I think what we learned here is, especially with multi-level disease, extensive disease, really consider that bypass much earlier. And my last case, a 51-year-old with leg pain, this is more of an acute type of situation, but I thought it showed some good teaching point. Patient, again, severe thrombosis, severe, how much of this is acute, how much of this is chronic is difficult to know. You can get an idea of the CTA. We thought really it was really a focal area. If we can open this up, we can improve the patient. I think it's important to understand, really don't see much of a profundifemoral in this patient. As we start treating this patient, you see that there was this branching compound, the profundifemoral artery that we're able to open up here. And we say, can we, and this is how the profunda is coming back and reconstituting the distal superficial femoral artery with a good preserved distal runoff. And here we tried to do some penumbra thrombectomy, and you can see that there's a really tight main branch of the profundifemoral, so a compound profundifemoral, and we're trying to go ahead and see if we can open into an SFA, which we're doing here with some thrombectomy. Unfortunately, as we pull back, we lost that profunda, and that's really something that you can't do. You have to protect those profunda. And if you have a question of a profunda lesion, I think these are patients that you want to treat with surgery early. So in conclusion, I think it's important to consider the patient as well as the lesion. Patient factors are important to help determine what your strategy is going to be. Length, location, vein status. Consider both alternatives. But I think bypass really should be considered in these patients, particularly common femoral, large SFA, small vessels, and the importance of best CLI, which I think we've already heard. Thank you.